I wanted to record a supplemental lecture on H. pylori treatment regimens because we sort of sped through them and I really want you to understand them. They can be quite confusing between the names and the drugs that are involved. So I really wanted to go through them so that essentially you would be comfortable with them. In terms of the treatment regimens, all of them are given for 14 days. That is shown to be the most effective in terms of eradicating H. pylori. Optimized bismuth quadruple is the one that is the most recommended in terms of preference, first line, for patients that have never been treated, patients that have been treated previously with some treatment for H. pylori. Empiric means that there is no antibiotic sensitivity testing, so they just give the drugs without testing for any antibiotic sensitivity. And then also those that have had proven antibiotic sensitivity. And then also for patients that have a penicillin allergy, because a lot of these treatment regimens contain amoxicillin. So this one is the preferred first-line therapy for all of those groups of patients. The rifabutin triple is the second one that is actually recommended for all three except for penicillin allergy because it has amoxicillin. This is actually the FDA approved product, Talicia, and it may not be as effective as the bismuth quadruple, but it is almost there. So essentially it is always the alternative, the first alternative you would use if you cannot take this bismuth quadruple. There's a new type of drug, PPI, out there now, vonoprazan. It's called a potassium competitive acid blocker, PCAB. And there's two drugs out there, Voquezna dual pack and Voquezna triple pack. And essentially the difference between the vonoprazan and PPIs is that even though it acts on the proton pump, it inhibits gastric acid secretion, it does have a little different mechanism and has a bigger anti-secretory effect, more rapid, more robust, and also more prolonged than that of standard PPIs. It maintains the intragastric pH greater than 6 for a lot longer than the PPIs. So this one is a very, very good PPI drug. And so they are sort of third in line after the rifabutin if for any reason they can't take the optimized bismuth quadruple. The 2 stars here mean that they may be considered when other treatments are not options. So they are not suggested for these 2 classes of persistent infections, but if for any reason they can't take any of the other drugs that are above them or alternatives, then essentially they can be taken. Lastly, there's a levofloxacin triple. And levofloxacin is a quinolone. Also, same thing as macrolide, the clarithromycin that is in some of these. It has to be tested for sensitivity. So one thing that to note in terms of penicillin allergy, if for any reason this bismuth quadruple is not able to be given, essentially you want to consider referral for penicillin allergy testing and or desensitization, because you do want to give as many antibiotics as possible for eradication. And if it for any reason the patient cannot take the bismuth, which you'll see the types of antibiotics that are in there, then usually they will try to desensitize the patient or really just confirm if there's an actual penicillin allergy. So just remember, the optimized bismuth quadruple is first line, then the rifabutin, then the Voquezna dual pack or triple pack, and then the levofloxacin triple. In terms of the in terms of the treatment naive patients, these are the components for each of the treatments. So in terms of the bismuth quadruple, these three drugs, the bismuth, the tetracycline, and the metronidazole, are all contained in packaged products that are FDA approved. So the Pylera actually contains the bismuth subcitrate, the tetracycline, and the metronidazole, and then you basically will add a PPI standard dose twice a day, 30 to 60 minutes before a meal. The other product, Halodac Therapy, that contains the subsalicylate bismuth. So essentially it's the same tetracycline and metronidazole in a different dosing, but it does have the bismuth subsalicylate instead of the subcitrate. Now, they're very expensive. Pylera is about $732 for a 14-day therapy. The Pylera is taken 3 capsules 4 times a day, and then you also add that PPI twice a day. And then the Halodac is taken 4 times a day. You can see here that they package it so that each dose is already packaged for 4 times a day. You're taking 4 tablets and capsule 4 times a day for 14 days, plus your twice a day PPI. Now, the 2 combination products are FDA approved. If it's given individually, it's not approved by FDA, but it's still used as treatment for treatment naive patients. So that's the 2 FDA approved products containing these 3 components: bismuth, tetracycline, and metronidazole. So you can see why this product or this treatment is given to penicillin allergies, because there's no amoxicillin. So metronidazole is used instead of amoxicillin. You don't have to know the actual doses and frequencies. Just know the drugs that are contained in this therapy. Next, we talked about rifabutin triple. So here are the components: omeprazole, the PPI, amoxicillin, and rifabutin. And you take 4 capsules 3 times a day, and it is FDA approved. But that's a lot of capsules 3 times a day, but it does already contain the PPI and 2 other antibiotics. The next step would be your Voquezna dual pack and triple pack. So the vonoprazan is 20 milligrams, and then the amoxicillin is 3 times a day. It is packaged so that you essentially can take the vonoprazan twice a day and then the amoxicillin 3 times a day. And for the triple pack, they're adding clarithromycin. The clarithromycin triple pack is reserved for patients with clarithromycin sensitive strains. So you have to test patients, or if they've never been exposed to a macrolide antibiotic, then they can take the triple pack. If they are not sensitive and are resistant, then they would take the dual pack, as long as they're not having a penicillin allergy. So basically, the potassium competitive acid blocker, vonoprazan, is recommended over standard PPIs if you're using the clarithromycin. And so basically that's something that is always noted, and you're always avoiding clarithromycin in patients with previous macrolide exposure. One thing that they do not do is they do not substitute doxycycline, which is another type of tetracycline. So tetracycline is the only drug that is approved for this treatment. The one thing to note is the way to choose between bismuth subcitrate and subsalicylate is basically whether or not the patient has a an allergy to salicylate. So if they do have an allergy, then you're going to be using the Pylera, which has the subcitrate, so that you don't run into problems with that allergy. So I would like you to know these treatments. Know that the bismuth is the first line, rifabutin second line, and then the PCAB is actually third line. And know what is contained in each of these treatments. You don't have to worry about doses or frequency. So this is an algorithm just showing how to decide what to use. So this is for people that have no antibiotic susceptibility testing, so they are being treated empirically, treatment naive patients that have never been treated before for H. pylori. You can see here if there's no penicillin allergy, you have more options. You have the BQT, which is the bismuth and tetracycline and metronidazole. You have the rifabutin triple, and that basically has the omeprazole, amoxicillin, and rifabutin. And then if those are not able to be taken, then you go into the potassium competitive acid blocker, vonoprazan, dual or triple therapy. In terms of penicillin allergy, the BQT, the bismuth quadruple therapy, is the one that is actually recommended first. And essentially, if for any reason they can't take this therapy, then that's where they're going to test for, formal allergy testing to see if possibly they could take, one of these other products with amoxicillin. In terms of treatment experienced patients, these are the people that are persistent in terms of their infection. And I don't expect you to know all of these therapies, but I wanted you to see what would happen with persistent patients. You still have the same bismuth quadruple and rifabutin triple. You also, you can see here that you might actually double the dose of the PPI when you have treatment experienced patients. And then, of course, you have the rifabutin Talicia, that essentially we talked about in the beginning, that is also available, that contains, amoxicillin, rifabutin, so that basically you can take it as a combination product. And that's FDA approved, so you can have, you're taking a little less medication. In terms of levofloxacin triple, this is of course going to only be used if you know that the patient is sensitive to levofloxacin, and you can see that amoxicillin is in it, so you have to watch about the penicillin allergy. If for any reason a person is allergic to penicillin, you can substitute the metronidazole for the amoxicillin. So it would still have two antibiotics, but you just wouldn't have the amoxicillin in the penicillin allergy patient. Here you can see that the Voquezna triple pack is recommended. So that is also for those that are sensitive to clarithromycin and don't have a penicillin allergy. And then the high dose dual therapy is a little different in terms of you are either doing the dual pack, vonoprazan, or PPI double dose twice a day or 3 times a day instead of the vonoprazan. So that's going to just depend on the patient in terms of what they have been treated with previously. This is a picture of the Voquezna triple pack, so you can see an AM and a PM dosing, so it's twice a day. You can see that there's 2 amoxicillins, 1 clarithromycin, and 1 vonoprazan that are given twice a day, and it's a 14-day therapy. So for treatment experienced patients without any kind of antibiotic testing, you're going to have these salvage regimens, which we went through. If they've previously had some type of clarithromycin triple therapy with a PPI, whether it be the the PCAB, the potassium competitive acid blocker vonoprazan, then you will go into optimized BQT or rifabutin. Those are always going to be your first two choices. And then if not, then you'll go into that high dose PPI or PCAB dual. So basically the dual one without the clarithromycin, because the patient's already been exposed to clarithromycin and may have the H. pylori may be resistant. Penicillin allergy, it's still going to be the optimized BQT therapy. And then if previously they did have the BQT primary therapy, but for some reason they didn't take it properly, they didn't take their PPI properly, then essentially you'll go ahead and try to really give them that BQT therapy and really monitor how they take it to make sure they're taking their PPI properly 30 to 60 minutes before their meals, twice a day, and also taking those antibiotics that are in there in terms of the tetracycline and metronidazole, and also the bismuth. You can see here pretty much it's the same algorithm in terms of what is given. So essentially you're really giving the same therapies for both those that have been on the BQT and also those that have been on the clarithromycin triple pack for the PPI or the vonoprazan. So in terms of, you really want to, the most optimal thing is to be able to test for antibiotic susceptibility in these patients because they've already been treated with some antibiotics. That way you make sure that you are treating them with antibiotics that are actually, going to eradicate that H. pylori. In terms of side effects, there are a lot of them. So this medication treatment for H. pylori is very complex, and adherence really decreases with multiple medications. The frequency of the administration, since they're going at least twice a day to 4 times a day with several pills. Intolerable adverse effects, and also they're very costly. So the tolerability is going to vary with different regimens, but common adverse effects are nausea and vomiting, abdominal pain, and diarrhea. With metronidazole and clarithromycin, you can have this metallic taste in the mouth, so that's something that's not too pleasant. For metronidazole, if you are giving higher doses, which you are here, if you drink alcohol with metronidazole, you'll get a reaction where you vomit every time you drink alcohol. So you really have to tell the patient to stop alcohol if they are taking a treatment that has metronidazole, and that would be your preferred bismuth quadruple. The tetracycline can cause photosensitivity. It shouldn't be used in children because of tooth discoloration. Bismuth salts can cause darkening of the stool and tongue, and so that can be really scary for patients. It does go away after they stop taking it, but to see a darkening of your tongue would be quite alarming. And they need to be used with caution and renal insufficiency, because then the bismuth will accumulate. Antibiotics can definitely cause diarrhea and oral thrush and vaginal candidiasis, and there's a risk of Clostridium difficile infection with antibiotics and with PPIs. In terms of the Clostridium difficile infection, that can cause a really, really serious diarrhea. So you really have to be careful and monitor patients for diarrhea. In terms of levofloxacin, it has some serious considerations: aortic dissection, arthralgia, CNS effects, hepatotoxicity, peripheral neuropathy, QT prolongation in cardiovascular patients, tendon rupture. So you really have to think about, that's why levofloxacin triple therapy is really only used in treatment experienced resistant patients, and only if the bismuth quadruple or the rifabutin, or even the the dual vonoprazan therapy is not able to be taken. The rifabutin can cause skin rash, discoloration of the urine, CYP3A4 interactions. So that's something that you have to be aware of. Rifabutin is a CYP3A4 inducer, so that is why you have to watch those interactions with other drugs. And then the vonoprazan can cause CYP3A4 interactions also. The one thing to be aware of, it can cause severe cutaneous reactions like Stevens-Johnson's and toxic necrolysis. So you really have to monitor patients for those severe cutaneous reactions. And it has the same concerns as the PPIs long-term that we talked about, and is contraindicated in very severe renal and hepatic insufficiency. And if it's a mild renal or hepatic, it may be adjusted in terms of dose. But for severe, it is really contraindicated in those patients. Lastly, in terms of the stress-related upper GI bleeding, we went really quickly through this. So critically ill adults can really develop stress-related mucosal damage, basically because of gastric or GI hypoperfusion. And then when they get reperfused with fluids and everything, then that can cause injury. So they can really get stress-related upper GI bleeding. You can see here that 75% will develop UGIB within 1 to 3 days of being in the ICU. So you really have to be careful and also prevent problems with these patients. The risk factors to initiate prophylaxis is coagulopathy. So basically, your platelets decrease, you have a real risk of clots, a general clotting malfunction, shock, and also chronic liver disease. And also those that are taking any type of neurocritical care, for stroke or for any type of neuro disease states, that they also are recommended to get prophylaxis. So the treatment of choice is a low dose daily PPI or H2RA. They can be given through feeding tubes enterally or IV. You can see here the doses. So in terms of the PPIs, they are preferred. So basically they really are the preferred product. The one thing that also is done is low dose. So you can see here that they are going to be given at the lowest dose possible. Cimetidine has a lot of drug interactions, so that would probably be one of the last ones that they would give because of the drug interactions, because all of these patients would be on probably a lot of drugs. One thing they found that previously they were giving prophylaxis to patients that had mechanical ventilation, but they have since found that there's no real evidence that that alone poses a risk factor. But most of these patients, a lot of them are on mechanical ventilation. So, these 3 risk factors are really the main thing that they look at to see if they have any of these risk factors, to give them prophylaxis. Once they are either, these are resolved or they are transferred out of ICU, they will actually be taken off of the PPI or the H2RA, specifically the PPI, because they don't want to give it long-term, specifically for all of those long-term adverse effects that are there. So that's something just so you know about stress-related upper GI bleeding, because it is so common in critically ill patients. Thank you.